Myself, Dr. Jibran Ahmed presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to read about paroxysmal nocturnal hemoglobinuria, which is a type of hemolytic anemia. Now, it is a rare acquired hematopoietic stem cell disorder which occurs due to acquired mutation in a particular gene called as PIGA gene. Now, PIGA stands for phosphatidylinositol glycan complementation A gene. And this gene is essential for the synthesis of a phospholipid anchor called as GPI. GPI stands for glycosyl phosphatidylinositol. Okay, and this particular phospholipid anchor is required for anchoring several complement regulatory proteins on the surface of blood cells, including the RBCs, WBCs, and the platelets. Now, because of this kind of mutation, it makes the RBCs abnormally sensitive to the hemolytic action of the complement proteins. Okay, so this is the only variety of hemolytic anemia which occurs due to an acquired genetic defect. Now, since the mutations are involving the hematopoietic stem cells, therefore, all its clonal progenies, that is the WBC, RBCs and platelets, all of them are affected and all of them undergo lysis. So, these patients, okay, they classically, present with pancytopenia. Okay. Now, let us try and understand the basic pathogenesis of paroxysmal nocturnal hemoglobinuria. So, we have first taken the RBCs over here. Now, for example, on the surface of the RBCs, there are certain phospholipid anchors called as GPI. So, these are the two very important phospholipid anchors, and their main function is to anchor or to attach certain very important complementary regulatory proteins, okay, that is CD55 or CD59, okay. So, these GPI phospholipid anchors, they help in attachment of complement regulatory proteins like CD55 and CD59. Okay, so CD55 also called as DAF and CD59 also called as MERL. Now, this CD55 and CD59, they are GPI linked proteins that normally regulate the complement activity. So, normally these proteins, that is the CD55 and CD59, they prevent spontaneous activation of alternate pathway of complement activation. So, normally they do not allow the complement pathway to get activated. Who do not allows? The CD55 and the CD59, normally they do not allow the complement activation, okay, and these are normally present on the surface of the blood cells, and they are attaching to the blood cells with the help of phospholipid anchor, that is the GPI. Okay, so normally this CD55 and CD59, these are complement regulatory proteins which prevents complement mediated lysis of the blood cells. Okay, now what happens in case of paroxysmal nocturnal hemoglobinuria, that this phospholipid anchor, that is the GPI, it becomes non-functional because of acquired mutation in the PIGA gene. Therefore, the CD55 or CD59 and multiple other complement regulatory proteins, they become deficient on the surface of the cell. Okay, they become deficient, they are no more present on the surface of the cells, and if they are not present, then the RBCs, WBCs and the platelets, they are going to become abnormally sensitive to the complement mediated cell lysis. Okay. Now, which are these complement regulatory proteins that are deficient in PNH? So, the deficient proteins, they include number 1, CD55 or DAF. DAF stands for decay accelerating factor. Now, normally CD55, they are an inhibitor of C3 convertase. Okay, this is one of the enzymes which is participating in the alternate pathway of complement activation. And by inhibiting the C3 convertase, okay, it is again not allowing the formation of membrane attack complex, which is responsible for complement mediated cell lysis. Okay, the second very important deficient protein is CD59, also called as MERL. It is MERL stands for membrane inhibitor of reactive lysis. So, normally this CD59 prevents interaction between C8 and C9 complement proteins, okay, which is one of the end steps of the alternate pathway of complement activation, and in the end they also prevent the formation of membrane attack complex. So, CD55 is a potent inhibitor of C3 convertase, okay, whereas CD59 prevents interaction between the complement proteins 8 and 9, and both of these factors ultimately they do not allow the formation of membrane attack complex, and this membrane attack complex normally is responsible for cell mediated lysis. Another protein which is deficient in PNH is your C8 binding protein. Now, these are the three most important complement proteins which are deficient. In addition to this, multiple other complement regulatory proteins are deficient as well. Now, normally in vivo, that is within our body, okay, the alternate complement pathway becomes activated. How? Because small amounts of C3b, okay, small amounts of C3b, they go and attach to the RBC surface, or they are present in the RBC surface, and they activate the C3 convertase enzyme, which ultimately is going to, form a complex with C4, C5, C8, C9, and ultimately a membrane attack complex is formed, which is causing blood cell lysis. Over here, RBC lysis. Okay, so normally in our body we have presence of CD55 and CD59 on surface of the RBCs, and CD55 is a potent inhibitor of C3 convertase, and CD59 is a potent inhibitor of MAC complex by not allowing the formation of, by not allowing the C8 and C9 to combine. So both the CD5 and the CD59 ultimately they do not allow the formation of membrane attack complex. So red cell lysis is prevented in normal individuals, okay, but in individuals who are having deficiencies of this proteins, if these proteins, GPI linked proteins, are not being able to attach to the RBC surface, then as a result red cell lysis occurs, because the RBCs becomes quite abnormally sensitive to complement mediated lysis. So in PNH, because of deficiency of CD55 and CD59, the blood cells, they become more susceptible to lysis, okay, and very important, lysis not only involves the RBCs, but they involve other blood cells including RBCs, WBCs and platelets, okay. All these three undergo lysis, and therefore characteristically these patients present with pancytopenia. Now, one very other important concept in the etiopathogenesis is that in normal individuals, small amounts of bone marrow cells have mutation in the PIGA gene, which is very much like that which is seen in PNH, okay. So in normal individuals, okay, small amount of bone marrow cells or the bone marrow hematopoietic cells, even in normal individuals, they are having mutation in the PIGA gene, but this occurs in small amount of hematopoietic stem cells, and these mutations are very much similar to PNH. And because the amount of mutation involving the amount of cell is very less, therefore they are not enough to produce the clinical features. But in conditions of autoimmunity, where for example some antibodies have formed against the GPI antigen, the percentage of these mutated cells increases and might give rise to PNH. So in certain conditions of autoimmunity where the body or the antibodies are formed against the GPI antigen, so in these individuals the percentage of these cells which are having the mutated PIGA becomes very high, and such individuals present with PNH. So what I want to tell you, that autoimmunity has an important connection with causation of PNH, and this is what explains the frequent association between PNH as well as aplastic anemia. Why? Because in aplastic anemia, one of the mechanism of aplastic anemia is via autoimmunity. So that is why, because this mutation is related with autoimmunity, and because aplastic anemia is also having autoimmunity as one of its mechanisms, therefore we say that PNH and aplastic anemia are frequently associated. Again, this is a very important concept. Now, typically remember, in individuals who are suffering from PNH, mutant clone is coexisting with progeny of normal stem cells that are not PIGA mutated. So normally an individual who is suffering from PNH, they will have one clone of cells which are having mutated PIGA gene, whereas they will have another clone of cells which are normal completely, okay. So depending on the degree of sensitivity to the complement, okay, there are three types of RBCs are found in PNH. Now in the PNH1, if you see, the RBCs have normal sensitivity to the complement. The PNH type 2 RBCs, the RBCs with intermediate sensitivity to the complement mediated lysis. And PNH3 type of RBCs, the RBCs with marked sensitivity to complement mediated cell lysis. Now the severity of hemolysis depends on the percentage of PNH3 RBCs. Now if the percentage of PNH3 variety of RBCs is less than 20%, we will have mild hemolysis. But if the percentage of PNH3 RBCs is more than 50%, we have chronic hemolysis, okay. Now let us look at the classification of the paroxysmal nocturnal hemoglobinuria. Now there are three important types. One is classic PNH, then PNH in setting of another disorder, and we are having subclinical PNH. Now classical PNH is having a very large clone of PNH, a very large clone of PIGA deficient or PIGA mutated RBCs. Therefore, they present with severe intravascular hemolysis, and bone marrow will show increased cellularity with erythroid hyperplasia. Now, PNH can also occur in setting of another disorders like aplastic anemia and myelodysplastic syndrome. Now, over here, the PNH clone is moderately sized clone, and they present with mild to moderate intravascular hemolysis. Whereas there is also subclinical PNH wherein the PNH clone is very small and there is no evidence of IVH, and this also occurs in the setting of aplastic anemia or myelodysplastic syndrome. Now, coming to the clinical features of PNH, they classically present with a triad of intravascular hemolysis, pancytopenia and thrombosis. Usually they are presenting in the third or fourth decade of life with features of chronic hemolytic anemia. And anemia that occurs is quite mild to moderate, okay? Patient presenting with weakness, pallor, mild jaundice or mild to moderate splenomegaly. Nocturnal hemoglobinuria is one of the classical features of PNH, and basically it occurs, nocturnal hemoglobinuria occurs due to the RBC destruction at night. Okay, it occurs so that the hemoglobinuria is noted first thing in the morning. Okay, that is why we are calling it as nocturnal hemoglobinuria. And why is it so that hemolysis is taking place at night? Because during sleep, mild respiratory acidosis occurs because of carbon dioxide retention. This facilitates the binding of the complement proteins to the red cells, and that is causing the RBC lysis more at night. So what happens that the patients who are undergoing hemoglobin breakdown at night, okay, they will see hemoglobinuria is noted first thing in the morning, okay, because of RBC destruction taking place at night. That is why the term nocturnal hemoglobinuria has been given. Now remember, hemosideриnuria is a constant feature and might lead to iron deficiency anemia in some patients. The most common cause of death in case of PNH is because of thrombosis, which is responsible for 40% of the patients of PNH. They present with venous thrombosis. So thrombus might affect the hepatic veins in the form of Budd-Chiari syndrome, which is rapidly fatal, or they might involve the mesenteric veins giving rise to abdominal pain, or they might involve the legs of the vein leading to deep venous thrombosis. Okay, now remember, this thrombosis, what is the reason of thrombosis? It is occurring because of complement mediated lysis, okay, which is stimulating the platelets, ultimately causing platelet aggregation. Now, anemia that occurs is usually mild to moderate in nature, but patients with large PNH clones can present with severe hemolysis. Okay, now other sign symptoms include bleeding because of thrombocytopenia and infections because of neutropenia. So such patients present with pancytopenia, and why they present with pancytopenia, we have already discussed that point. Around 5 to 10% patients of PNH, they also develop AML or MDS syndrome, which occurs because of certain genetic damage which has occurred to the hematopoietic stem cell. Coming to the laboratory diagnosis of PNH, the peripheral blood smear, if you see, they show pancytopenia, anemia which is mild to moderate, and if iron deficiency anemia is present, then microcytosis along with hypochromia will be there. Under the urinary examination, there are two things that is happening. Now try to understand, because there is an intravascular hemolysis. So what is happening? The RBCs are getting broken down. So what is going to happen? The free hemoglobin will be released into the circulation, and that free hemoglobin is going to bind with haptoglobin. Now there is only a limited amount of haptoglobin that can bind with the free hemoglobin. Now, when the capacity to accommodate the free hemoglobin is finished, or if the capacity of the haptoglobin is saturated, in that case the free hemoglobin starts to come in the urine, or they start to enter the kidney. Now this hemoglobin, they can enter the kidney and they can be filtered as hemoglobin in the urine, and this condition is called as hemoglobinuria, and this is quite an intermittent feature, and this can be detected by benzidine or orthotolidine test. Okay, now while hemoglobin is passing down the kidney, some part of the hemoglobin, the hemoglobin or the heme part containing the iron, they get reabsorbed in the renal tubular epithelial cell. Okay, and that storage form of iron inside the cell, they get converted to ferritin, ultimately giving rise to hemosiderin. So what happens that when these tubular epithelial cells containing hemosiderin or ferritin, when they die, then they will also shed the hemosiderin which is contained in that particular cell, and that is responsible for hemosideриnuria. So urinary examination of such patients will show hemoglobinuria and hemosideриnuria. This hemosideриnuria is classically detected with the help of Pearl stain also called as Prussian blue staining on the urinary sediment, and this feature of hemosideruria is constant. Okay, it is indicative of chronic intravascular hemolysis. So we can appreciate on the left hand side, this is how hemoglobinuria looks like, and on the right hand side we can see the pearl stain showing the deep purple or purplish blue color of the iron deposits. Okay, this is the hemosideruria that we can appreciate. Now the third important group of tests, so we have already seen the PBS, we have seen the urinary examination. Now the third important group of tests is the complement based assays. Now these demonstrate unusual sensitivity of the PNH RBCs to hemolytic action of the complement. Now these tests, they are now outdated, no one is performing these tests, but for MCQ these tests becomes very important. Okay, and these tests, they have been replaced now by flow cytometric analysis. So now we are going to discuss two very important complement based tests. So one is your sucrose hemolysis test, also called as the sugar water test. It is a standard screening test. Over here what is happening, that in a test tube we are having ABO compatible normal serum, which is basically a source of complement and antibodies. Okay, along with that we are adding a sucrose solution over here. Now this sucrose solution is favoring the attachment of immunoglobulins which are present in the normal serum as well as the complement to the red cells. So they facilitate the attachment of immunoglobulins and complement to the red cells. Okay, so this is very important. And now to this mixture we are adding the red cells from the patient is added to this mixture. After this, the mixture is centrifuged and incubated at 37 degrees Celsius. Now the amount of hemolysis quantified spectrophotometrically, okay, is going to decide whether PNH is present or not. If the amount of hemolysis is more than 10%, which it is suggestive of PNH. Okay, remember this test, that is your sucrose hemolysis test or sugar water test, they are more sensitive but they are less specific as compared to the HAMS test, which is another complement based assay. So the next test that we are going to see, it is the acidified serum test, also called as the HAMS test. Now what is the principle of the HAMS test? Acidification of the serum, okay, acidification of the serum activates the complement via the alternate pathway and causes hemolysis of the red cells if they are abnormally sensitive to the complement. So what will happen again over here, we take fresh normal ABO compatible serum which is a source of complement protein, that is acidified till pH 6.5, and then the patient's red blood cells are added. Now after addition of the red cells, the percentage of hemolysis is noted. Now if the RBCs are PIGA deficient or PNH RBCs, okay, they if PNH is present, then around 10 to 15% lysis will be there. So 10 to 50% lysis of the RBCs is indicative of PNH. Now HAMS test, if you see, it is done only if sucrose hemolysis test is positive, and this test is also positive in some other conditions like congenital dyserythropoietic anemia type 2, which is also called as HEMPAS. Now the fourth very important variety of test that is now commonly done, that is assay based on GPI linked protein. Now this has replaced the HAMS test as definitive test for diagnosis of PNH. Now it is basically there is flow cytometric analysis of GPI linked protein, that is CD55 and CD59. Now in PNH, a population of red cells is present, deficiency in more than one GPI linked protein. Now in PNH, remember, you will have two things. You will have a population of red cell will be present, and there will be another population of red cells which will be deficient in more than one GPI linked protein. So two population of cells will be seen in case of PNH. So on the left hand side, as we can appreciate over here, this is the flow cytometric analysis. On the y-axis we are having CD59, on the x-axis we have CD55. So this is the flow cytometry done from a normal person. You will see that you will only see a population of RBC that is containing both CD55 and CD59. Okay, now the second, on the right hand side, this graph, if you see, there are two population of cell. One population of RBCs which are having CD55, CD59, that means a normal population of RBC is there. There is another population of RBC which is without any CD55 or 59. So over here on the right hand side, this is the flow cytometric analysis from a patient who is suffering from PNH, and we are having a mixed population of cell. Okay. Now the last very important lab diagnosis that we are going to do, this is also flow cytometry based, called as fluorescent aerolysin assay. Now this is also called as FLAIR based on FCM. Now FLAIR stands for fluorescent labeled proaerolysin. It binds selectively and with a high affinity with the GPI anchor on the granulocytes and provides more accurate assessment of the GPI anchor deficiency than conventional flow cytometry using antibodies. So with this, we have completed in details about the PNH, wherein we have read in details about the different lab diagnosis. We have also seen, very importantly, we have also seen the important classification of PNH, and we have seen the clinical features in details as well, along with the etiopathogenesis. So thank you very much for watching this particular video.